So now we'll look at the positional range of purposeless masticatory function. Let's say we want our patient to go into a protrusive movement. Now, usually protrusive, the lateral pterygoid provides translation. Is that what we're going to get? But if we say, I want to see your patient in protrusive movement, show me right now, Dr. Boyd, on your articulator or on your patient. The patient will protrude and we have their incisal edges still touching. That's called protrusion as a functional movement. That doesn't happen in mastication. What are you doing? What purpose does that serve? But it's a parafunctional move that happens when people are asleep sometimes. We've just flip-flopped some of the terminology, so we don't look for that. We don't assume that could be pathologic because we called it functional movement. So in protrusion, if a protrusive resistance sometimes ends up, these incisors are still engaged. What does someone's teeth look like that has a protrusive resistance component of their parafunction? The terminology of constricted envelope of function is completely misleading because nobody chews like that. They'll say he chews like a rabbit. So you get the image of how these teeth are worn, but that's not how real function works. Real parafunction doesn't work like that. There is no constricted envelope of function. It's a parafunctional act. Parafunctional protrusive resistance is what's happening. It gets that look of the teeth that this chews like a rabbit gives. But unless you think of this, you really won't be on top of how to treat the patient. Otherwise, you're trying to treat how they chew food as opposed to how they're parafunctioning. So if someone didn't have any incisal overlap at all, sometimes that creates a natural barrier in the patient's teeth. Their condition tends to go there. And these protrusive parafunctioners. What if there was no incisal overlap at all, like a class 3 patient, incisal edge-to-edge patient, a flat plane splint patient that wasn't a flat plane splint patient a week ago, but you just gave them one. And here is the purposeful condylar position, edge-to-edge. There's no reason to go beyond that. Parafunction doesn't care. It's out to make you look bad. It will do to that patient whatever it needs to do to make the patient hurt and to make you look like an idiot because you can't figure it out. In protrusion like this, you can get posterior contact, you get joint strain, it's terrible. And interestingly, when someone protrudes, their ability to contract the elevator starts to go down. It's a little less efficient. I haven't done all the reading on that yet, but you'll find that I think that's one of the cool things about apnea devices. As they open and are more protruded, the elevators are not as intense as they could be. So we'll put a flat plane splint in there. And patients can go flying right off the end of that. And if you don't ask them to do that, you wouldn't know that they do it because they didn't have to before. If they have a degree of incisal overlap and they go forward and they're pressing on their canines or something like that, and they're symptomatic, you give them a completely flat plane splint, and they do okay for a few days, and all of a sudden they get this weird stiff and sore neck, and they're hurting behind their eyes. You go, what is the deal? Have them go forward as far as they can. And when they squeeze the splint, they'll go, oh, that's weird. I know I don't do that. Why do you know that? Because that doesn't feel good. I'll bet you that's what you're doing. We'll say, well, you've got hypermobile joints. You weren't hypermobile before you put the splint in. The muscular activity is causing this to be hypermobile. So the presence of a splint, which is a new occluding scheme, can allow for new parafunctional positions. So when you put a splint in someone's mouth and their condition changes, they're doing something new that they couldn't do before, but now that they can. I always imagine that the patient's condition is trying to make me look bad. And when the patient tells me, well, I think that maybe if you could just make this a little thicker, and I say, you know what your condition just told you, tell him to make it thicker, because that will really make you feel worse, and he'll probably do it. Because you want to do whatever the patient says, because they're not feeling good now, and you want them to like you and want to do the right thing. I say, you know what your condition just told me to do? Oh man, if I do that, we're in trouble. Oh, okay. So you just made them a splint. And you said, well, this person, I think they're going protrude. They're going way out there. How can I modify the occluding scheme to manage this? First thing I need to do is rule number one, minimize muscle contraction intensity. I need incisal edge contact. How do I do it? Well, I can make it a big, huge extension on this thing. Well, that'll work. But it just looks kind of dumb because they got this plate sticking out of their mouth for these intense protruders. And I've made them that way. That's the working part right there. We need to get incisal edge contact. Perhaps we don't have to stick with a maxillary splint. If you made something on the mandible, that might look and work better. You'll get incisal edge contact in protrusive. There's rule number one accomplished, minimize muscle contraction intensity. So we're sort of getting into splint design now.